Welcome back to CareFlow Academy. I'm so glad you've made it back. In today's lesson, we're diving into one of the most important topics you'll see on the NCLEX, cardiac disorders. Now, I know cardiovascular questions can seem overwhelming. There are so many diseases, so many symptoms, and sometimes it feels like every cardiac patient looks exactly the same. But what if I told you, most cardiac questions aren't really testing whether you memorized every disease. They're testing whether you understand what's happening to the blood. Can the heart pump? Can blood reach the tissues? Can oxygen get where it's needed? Or is blood backing up somewhere it shouldn't? Once you understand those concepts, the symptoms begin making sense. And when the symptoms make sense, the correct answer becomes much easier to recognize. So today, we'll continue using our CARE method to break down cardiovascular questions exactly the way you'll see them on the NCLEX. So if you're ready, let's get started. By the end of this lesson, you'll be able to recognize several of the most common cardiovascular disorders tested on the NCLEX. We'll identify key assessment clues that help you quickly recognize cardiac conditions. Compare left-sided and right-sided heart failure. Discuss how to prioritize care when circulation and perfusion become impaired. And finally, we'll apply everything we've learned using our CARE method with real NCLEX-style practice questions. Remember, the goal isn't memorization. The goal is understanding why the body is responding the way it is. Before we jump into individual cardiac disorders, let's start with the bigger pattern. Cardiac questions are usually about one major idea. Can the body get enough oxygen-rich blood? So when you see a cardiac question, ask yourself, is the heart pumping effectively? Is blood flowing forward? And are the tissues getting oxygen? Because once perfusion drops, the body starts leaving clues. The NCLEX is not just testing disease names, it's testing whether you can recognize when oxygen delivery, perfusion, cardiac output, or tissue function is being affected. When you're stuck, think, what body system is failing first? That question helps you move from memorizing symptoms to understanding the problem. Now let's make this practical. Ask yourself, is blood getting where it needs to go? If the answer is yes, the tissues can receive oxygen, the organs can function, and the body can maintain stability. But if blood flow decreases, oxygen delivery decreases, organs begin to struggle, and symptoms start to appear. That is why cardiac clues often show up as signs of poor perfusion. So instead of trying to memorize every cardiac disorder separately, follow the blood. Wherever blood flow is reduced, oxygen delivery decreases, and that's where you'll find the problem. Now let's talk about one of my favorite memory tricks. Left equals lungs, and right equals the rest of the body. That's it. That's the shortcut. Let's start with the left side of the heart. If the left ventricle can't pump blood forward, blood backs up into the lungs. And when fluid enters the lungs, you'll begin seeing pulmonary symptoms like crackles, shortness of breath, and orthopnea. Now let's look at the right side. If the right side can't pump blood forward, blood backs up into the body's venous system. So instead of lung problems, you'll begin seeing fluid collecting throughout the body. This can be seen as peripheral edema, jugular venous distension, weight gain, ascites, and hepatomegaly. So remember this phrase, left equals lungs, right equals the rest of the body. If you remember nothing else about heart failure, remember that. Now let's build on that foundation. Heart failure occurs when the heart isn't pumping blood efficiently enough to meet the body's needs. So, what clues should immediately grab your attention? With heart failure, we can begin to see crackles, dyspnea, orthopnea, fatigue, edema, weight gain, and decreased activity tolerance. Notice something interesting. Some symptoms involve breathing, others involve fluid retention. That's because heart failure often affects both sides of circulation. Now, let's think about nursing priorities. Think, what actions can I take to ensure that my patient's condition is not worsening? We can place them in a high Fowler's position to assist with their breathing. We can provide oxygen when needed in order to perfuse them. We should monitor lung sounds to assess the severity of their fluid backup. We can take daily weights first thing in the morning after the patient's first void to ensure that their fluid retention is either improving or, at the very least, not worsening. And it's very important that we maintain strict intake and output. One NCLEX favorite: daily weights. Why? Because they're the most accurate indicator of changes in fluid volume. A patient may not notice swelling right away, but the scale often notices first. Now let's shift gears to myocardial infarction, or an MI, commonly known as a heart attack. What's actually happening during an MI? A coronary artery becomes blocked. This means that blood can't reach part of the heart muscle. Without oxygen, the heart muscle begins to die. That's why classic symptoms include chest pressure, crushing chest pain, pain radiating to the jaw and left arm, diaphoresis, shortness of breath, and nausea. But here's an important NCLEX reminder. Not everyone presents with those classic symptoms. Women, older adults, and patients with diabetes may experience more subtle symptoms, such as fatigue, indigestion, nausea, or only mild discomfort. That's exactly why the NCLEX loves these patients. Don't wait for textbook symptoms. Recognize the underlying lack of oxygen reaching the heart muscle. Now that we've recognized an MI, what comes next? Remember, save the heart muscle. Every minute matters. Every minute that blood flow remains blocked, more heart muscle is permanently damaged. Now let's walk through our potential priority interventions. Which actions directly address this patient's immediate needs? The patient should be placed on cardiac monitoring. An ECG should be obtained as soon as possible. IV access should be established. Oxygen should be provided if indicated. Prescribed medications should be administered promptly, and preparations should begin for reperfusion therapy if needed. The goal isn't just about treating chest pain. The goal is restoring blood flow as quickly as possible, because the faster blood flow returns, the more heart muscle can be saved. Let's look at another topic the NCLEX loves to test: hypertension. But more importantly, how do we know when hypertension becomes an emergency? Many patients live with chronic hypertension for years. In fact, most have no symptoms at all. Unfortunately, that doesn't mean hypertension isn't an issue. Over time, consistently elevated blood pressure damages blood vessels throughout the body. Eventually, that damage can affect the brain, kidneys, eyes, and heart. Now let's compare that to a hypertensive crisis. This is long past just a high number on the blood pressure monitor. This is high blood pressure that is actively damaging organs. Look for clues like a severe headache, vision changes, chest pain, altered mental status, or new neurological symptoms. Here's an easy way to remember it. Chronic hypertension is usually a long-term problem. Hypertensive crisis is causing damage right now. When you see evidence of organ damage, treat it like the emergency that it is. Let's talk about peripheral arterial disease, or PAD. Instead of asking yourself, what is PAD? Think, what can't the blood do? The answer is, blood can't get to the tissues. Arteries carry oxygen-rich blood away from the heart. When those arteries become narrowed, the tissues receive less oxygen, and the body leaves us clues. This can manifest in symptoms such as cool extremities, pale skin, weak pulses, pain with walking, and delayed wound healing. That pain with walking has a name: intermittent claudication. This happens because muscles require more oxygen during activity, but narrowed arteries just can't deliver enough blood. One memory trick to remember is cold, pale, and painful. immediately start thinking, peripheral arterial disease. Now let's compare PAD with chronic venous insufficiency. Notice something important. CVI isn't an arterial problem. It's a venous problem. Blood can get to the legs just fine. The problem is, it can't efficiently return back to the heart. When blood sits in the legs, pressure builds and fluid leaks into surrounding tissues. Eventually, we begin seeing edema, brown discoloration, venous ulcers, and aching legs. Compare those findings to PAD. PAD was cold, pale, and painful. CVI is swollen, stagnant, and pooling blood. Here's one of my favorite CareFlow shortcuts. PAD, blood can't get there. CVI, blood can't get back. If you remember those two phrases, the answers become more evident. Before we move into practice questions, let's quickly review everything we've learned. For our left-sided heart failure, think breathing. Crackles, dyspnea, and orthopnea, these all affect the lungs. With right-sided heart failure, think body. You'll begin to notice edema, jugular vein distension, and they may develop ascites. Myocardial infarctions? Patients may experience chest pressure, diaphoresis, and the classic symptoms such as pain radiating to the jaw or left arm. Peripheral arterial disease. Remember, cool, pale, and painful. While chronic venous insufficiency manifests as edema, brown skin discoloration, and venous ulcers. Notice what we're doing. We're not memorizing diseases, we're recognizing patterns. And that's exactly how the NCLEX wants you to think. Now let's put everything together. Here's our first practice question. A nurse is caring for a client with heart failure. Which finding requires immediate intervention? Is it A, weight gain of 1 pound this week? B, bilateral crackles and increasing shortness of breath? C, mild ankle edema? Or D, fatigue after ambulation? Let's begin breaking this down using our CARE method. We'll begin with our concept. The NCLEX is testing whether we can distinguish between left-sided and right-sided heart failure. Remember the tip that we went over in the beginning? Left equals lungs and right equals everything else. So immediately we should begin thinking airway, breathing, and circulation. When breathing begins to fail, that becomes the priority. Now let's analyze our clues by separating the choices into two categories, left and right symptoms. Weight gain of 1 pound per week and mild ankle edema? These are symptoms of right-sided heart failure. Bilateral crackles and increasing shortness of breath and fatigue after ambulation? These sound like left-sided heart failure symptoms. Now that we've separated the choices, let's rule out a few of them. Out of the two categories, which one requires immediate attention, left or right-sided? Weight gain and mild ankle edema, although classic symptoms of right-sided heart failure, do not immediately threaten the patient's ability to oxygenate. We can safely remove these two options. The left-sided symptoms indicate an issue with the patient's breathing. They become our priority. Now, out of the two symptoms, which require immediate attention? Fatigue after ambulation can be dangerous, but fatigue alone doesn't suggest an immediate threat to oxygenation. We can go ahead and rule out D. That leaves B. Let's go ahead and execute our decision. When a heart failure patient begins developing worsening pulmonary symptoms, immediate intervention is required. Crackles and shortness of breath indicate that fluid is accumulating in the lungs. And once oxygenation becomes impaired, every organ in the body becomes affected. The correct answer is B. Bilateral crackles and increasing shortness of breath. Notice we didn't just memorize heart failure symptoms. We understood what the symptoms were telling us and were able to separate them into categories. After that, we assigned priorities to each category and successfully recognized that breathing became the priority. That's exactly how nurses think in real clinical practice. Let's try another one. A patient arrives in the emergency department reporting chest pressure radiating to the left arm and jaw. Which action is the nurse's priority? Is it A. Obtain a 12-lead ECG, B. Administer oxygen at 2 liters per minute via nasal cannula, C. Obtain a complete set of vital signs, or D. Establish IV access for possible medications? Let's start with the concept. This question is testing our ability to identify the priority nursing action. Notice that the question isn't asking us for the diagnosis. It's asking, what should the nurse do first? Whenever you see a priority question, immediately think airway, breathing, circulation. Then ask yourself, which intervention gives me the most important information or has the greatest immediate impact on patient safety? Remember, several answers may be appropriate. Your job is to determine which one comes first. Now let's analyze our clues. The client reports chest pressure, pain radiating to the left arm, and pain radiating to the jaw. Those are classic findings of acute coronary syndrome. Immediately begin thinking, possible myocardial infarction. Now let's organize the answer choices. We have 2 assessment actions: obtaining a 12-lead ECG and obtaining a complete set of vital signs. We also have 2 interventions: administering oxygen and establishing IV access. Here's the important question. Which of these tells us what is happening inside the heart so we know what to do next? Let's work through each answer. The question isn't asking us which choice is the right answer. It's asking us, what would you do first? So instead of ruling them out, let's assign each one a priority ranking. We'll decide whether each answer belongs in the number 1, 2, 3, or 4 spot as we go. Choice A, obtain a 12-lead ECG. The ECG quickly identifies myocardial ischemia or infarction. It tells us whether the patient may be experiencing a STEMI or another acute coronary syndrome. Most importantly, it guides every treatment decision that follows. Right now, this becomes our number 1 priority. We'll keep it there unless another answer proves to be even more important. Choice B, administer oxygen at 2 liters per minute. Oxygen may be appropriate, but we should be giving oxygen only when the patient is hypoxemic or showing signs of respiratory distress. Chest pain alone does not automatically require oxygen. Since we already have the ECG ranked first, this does not move into the number 1 spot. For now, we'll place oxygen in the number 4 position because it depends on the patient's oxygen saturation. Choice C, obtain a complete set of vital signs. Vital signs are always important. They provide valuable baseline information and help us monitor the patient's condition. But they still don't tell us whether the heart muscle is being deprived of blood flow. So the ECG remains number 1. Vital signs move ahead of oxygen. Our ranking is now number 1, ECG, number 3, vital signs, number 4, oxygen. We still have 1 answer left. Choice D, establish IV access. IV access is an appropriate intervention. The patient will likely need medications, blood work, and possibly reperfusion therapy. Those treatments can't happen efficiently without IV access. It's more urgent than obtaining baseline vital signs, but it still comes after identifying what's happening with the ECG. So let's execute our final rankings. Number 1, obtain a 12-lead ECG. Number 2, establish IV access. Number 3, obtain a complete set of vital signs. Number 4, administer oxygen if indicated. The correct answer is A. Obtain a 12-lead ECG. Remember, in suspected myocardial infarction, time is heart muscle. The faster the ECG is obtained, the faster treatment can begin. Every minute saved means more heart muscle can be preserved. Let's finish with one more practice question. A nurse assesses a client and notes cool lower extremities, weak pedal pulses, pain when walking, and pale feet. Which condition should the nurse suspect that patient have? Is it A, chronic venous insufficiency, B, heart failure, C, peripheral arterial disease, or D, deep vein thrombosis? Let's go ahead and break this down with our CARE method one last time. Now let's break this question down one more time using the CARE method. C, concept. The NCLEX is testing our ability to identify a circulation problem. Whenever you see symptoms affecting an extremity, immediately ask yourself, is this a blood flow problem? Is blood having trouble getting to the extremity? Or is blood having trouble returning from the extremity? That single question will often help you separate arterial disorders from venous disorders. A. Analyze. Now let's take a look at our clues. The client has cool lower extremities, weak pedal pulses, pain when walking, and pale feet. Each of these findings points toward decreased arterial blood flow. How do we know this? Because the blood is having a hard time getting to the extremity. One clue is especially important: pain when walking. Why? Because this suggests claudication. Claudication occurs when the muscles require more oxygen during activity, but oxygenated blood cannot reach the muscles because arterial blood flow is reduced. The key idea is this: the tissue is not receiving enough oxygenated blood. That explains why the feet become cool, pale, and painful. R. Rule out. Let's start with option A, chronic venous insufficiency. This condition occurs when blood has difficulty returning to the heart through the veins. Clients typically develop edema, warm skin, and aching or heaviness in the legs. Our client has cool, pale feet with weak pedal pulses. Those findings point toward an arterial problem, not a venous one. So we can rule this answer out. Now let's look at option B, heart failure. Heart failure affects the heart's ability to pump blood effectively. Clients commonly develop fluid overload, pulmonary congestion, and peripheral edema. Although circulation is affected, heart failure does not typically cause localized cool extremities with diminished pedal pulses and claudication. So we can rule this answer out as well. Finally, let's evaluate option D, deep vein thrombosis. A DVT is a clot within a vein. Blood can still enter the extremity through the arteries. Clients commonly present with unilateral swelling, warmth, redness, tenderness, or calf pain. Those findings don't match what we're seeing in this question. Instead, our client has decreased arterial circulation, so we can rule this answer out. And finally, E, execute. That leaves us with peripheral arterial disease. Peripheral arterial disease causes reduced arterial circulation to the extremities. As a result, the tissues don't receive enough oxygenated blood. That's why the feet become cool, pale, painful, and why the client experiences pain while walking. Whenever you see cool extremities, weak pedal pulses, pallor, and claudication, immediately begin thinking peripheral arterial disease. The correct answer is C, peripheral arterial disease. Notice how we didn't have to memorize every vascular disorder. Instead, we asked one simple question: is blood having trouble getting to the extremity, or is blood having trouble getting back to the heart? Once we recognized this was a problem with blood getting to the tissues, the correct answer became much easier to identify. Remember, the CARE method isn't about memorizing diseases. It's about recognizing the underlying concept the NCLEX is testing. When you focus on the concept first, the correct answer often becomes much more obvious. Before we finish, let's review the key takeaways. Remember, for the left side of the heart, think lungs, and the right side of the heart, think the rest of the body. For a myocardial infarction, your priority is restoring blood flow as quickly as possible. For peripheral arterial disease, blood can't get to the extremity, while chronic venous insufficiency is that blood can't get back from the extremity. And don't forget, heart failure questions often become oxygenation questions. Always ask yourself, how is the heart's decreased pumping ability affecting oxygen delivery to the body? One final thought. The NCLEX loves cardiovascular disorders because they require you to think about several concepts at the same time: oxygenation, perfusion, and patient safety. If you focus on those core concepts, instead of trying to memorize every disease, you'll approach cardiovascular questions with much more confidence. And that's exactly what the CARE method is designed to help you do. Congratulations on completing Module 12. I hope you're beginning to see that the NCLEX isn't about memorizing endless facts. It's about recognizing the concept being tested. That's why it's so important to understand why you're choosing an answer, not just what the answer is. And that's where the CARE method can help. If you found this lesson helpful, go ahead and like this video and subscribe to the channel. That way, you'll be notified whenever a new module is released and can continue building your NCLEX confidence one concept at a time. In our next module, we'll begin exploring neurological disorders. You'll learn how to quickly recognize neurological assessment findings, differentiate common neurological conditions, and confidently break down neurological questions using the same CARE method you've learned throughout this series. Thank you so much for learning with me today. Don't forget to take care of yourself. Keep practicing. Keep believing in yourself. And I'll see you in the next one.